Okay, good afternoon, everyone. Allison and I would like to welcome all of you and thank you for joining us today. Before I introduce our presenter today and we get started, I'd like to begin with a land acknowledgement. I would like to begin by acknowledging my sincere gratitude for the opportunity to work and live on this beautiful land that has been occupied by First Nations since the beginning of time. I am currently in Ottawa and acknowledge that I am on the unceded, unsurrendered territory of the Algonquin Anishinaabe Nation. PCMCH recognizes that Indigenous practices of health and well-being have been in place in this territory since time began and are maintained to this day. We are committed to honoring and improving our knowledge on these practices. We recognize the harms and mistakes of the past, and we take meaningful steps toward reconciliation by building and improving relationships with First Nations, Inuit, and Métis people. So I just want to tell a little story about my parents and my older brother keep bees in Carbon, Alberta. And when they were bringing a new hive home a couple of weeks ago, one single bee got loose in my mother's car. I was there while it happened for the Children's Healthcare Canada conference in Calgary. And the night before the conference, my brother and my young niece and nephew decided we had to save the bee. So ever so carefully, we guided the bee into a cup, covered the cup with a piece of paper, and then safely placed it into the bushes beside my brother's house. And then my young nephew proclaimed, "We are the bee savers." And why am I telling this story? The very next morning, to open the conference, an Indigenous elder welcomed all of us and opened the conference by telling the 500 or so people there that whatever you do, do not kill bees. Use a cup, cover it, and save it. Bees are very important for many reasons, one being that bees symbolize community, hard work, and the interconnectedness of life. That was such a moment of connection for me to my family the night before, to nature and to our bees, and to life and to the unspeakable connection that we have to each other and how life unfolds. Before we start, and I introduce Dr. O'Donnell, a few housekeeping items. Please enter your questions in the Q&A function, and you can put them in the Q&A function, or you can raise your hand. We're going to save 10 to 15 minutes at the end for questions and answers, and so you can put it in the Q&A, or at the end you can raise your hand and we can unmute you. So without further ado, I would like to introduce today's presenter, Dr. Holly O'Donnell. Dr. O'Donnell is a licensed clinical psychologist and assistant professor of pediatrics at the University of Colorado School of Medicine and Barbara Davis Center for Diabetes in Colorado. Her research interests include the psychological impact of screening for type 1 diabetes, genetic risk, and autoantibodies, psychological aspects of living with type 1 diabetes, for example, the fear of hypoglycemia and diabetes distress, and the integration of psychological care into the clinic setting. She is a member of the psychosocial committees for TEDdy and TrialNet and serves as the consulting psychologist for the autoimmunity screening in kids study. She is currently the principal investigator of a grant adapting cognitive behavioral therapy to address anxiety in individuals with early stage T1D. Clinically, she enjoys working with patients of all ages and their families to address psychological impacts or aspects of living with type 1 diabetes, both early and established T1D, and to improve quality of life. Welcome, Dr. O'Donnell. I'll pass it over to you.
Okay, in the last 24 months, I have done some consulting for Sanofi, so those are my disclosures, and we can go to the next slide. Okay, so what are we going to do in the next little bit of time here? My goal is to review the psychological impact of screening and identifying early stage type 1 diabetes. Hopefully along the way, answer the question of why it might be important to understand the psychological impact, and how do the decades of research we've actually had present in current clinical care settings as we move screening from the research realm into clinical care, and highlight some knowledge gaps. There is still a lot we don't know about this population, which makes it exciting to work in because we continue to ask questions and try and seek answers and ways to better support this population. Okay, next slide. So many in the audience can probably explain this image more eloquently than I can, but just to make sure we're all on the same page this morning, I thought I would just quickly review terminology for early stage type 1 diabetes, and that way when I'm referring to things like stage 1 or stage 2, we're all on the same page. We're all very used to seeing kids when newly diagnosed with type 1 diabetes, which now is being referred to as stage 3 type 1 diabetes. But we know from decades of research the autoimmune process begins well before the individual presents with symptoms to the hospital or to the doctor's office. And so the image here shows that some people are at increased genetic risk for type 1 diabetes. And then there's some triggering event that starts the autoimmune process attacking the beta cells. And when that happens, we can detect the islet autoantibodies in the blood. And so in stage 1 of type 1 diabetes, we're referring to when there are 2 or more islet autoantibodies present in the blood, but normal glycemia. In stage 2, those islet autoantibodies are still around, but the patient starts to have dysglycemia. So if they were to do an oral glucose tolerance test, we start to see their beta cells having a bit of a tough time. And then by stage 3, enough of the beta cells have been destroyed that they have dysglycemia, symptoms of diabetes, and usually need to start insulin. Okay, we can go to the next slide. And so here's just a different way of how we're going to look at it from stage 1, 2, and 3. Okay, next slide. So screening has, in the past several decades, historically been conducted in research studies and usually among first-degree family members of individuals with type 1 diabetes. But now we are seeing that screening has moved away from strictly being in a research study and strictly being with individuals who are high risk and is becoming increasingly common in clinical settings and in the general population. So I put this slide up here just to show a sampling of screening programs. They're all a little different in terms of who they're screening, who they're enrolling, et cetera. But the idea is that it is rapidly growing and it is quite a hot topic right now. Okay, next slide. And there's also actually a fair amount of growing direct-to-consumer options for screening. So families can, order their own test kits, et cetera. I'm not intimately familiar with each of these different, T1D Scout, et cetera, programs. But the point is that it's really growing and that we're likely to see a lot more of these patients in our clinical practice. Okay, next slide. So I would argue that as screening expands, especially among the general population, where we have less research about how they're responding to this information, it's important that we start to really focus and understand the psychological ramifications of early detection and islet autoantibody screening. Okay, next slide. So before I get started sharing what we know and also what we don't know about the psychological impact of an early stage type 1 diabetes diagnosis, I want to familiarize you all with a couple of studies and programs that I'm going to cite throughout this presentation. So the TEDdy study recruited children at genetic risk for type 1 diabetes at birth and followed them until they developed type 1 diabetes or reached age 15. About 40% of the families with children who were identified as high genetic risk for type 1 diabetes agreed to participate in the TEDdy study. This is important when we think about the sample and what conclusions we can or cannot make to general population. And in the TEDdy study, children were seen regularly. And the child's risk of developing clinical type 1 diabetes was repeatedly communicated to families using a standardized protocol There was lots of information provided to these families about the signs and symptoms of type 1 diabetes. Um, and then the next study I want to mention is the ASK study. And the ASK study screen is meant to be a general population study. They don't exclude people who have a family history, but the majority of the people in the ASK study do not have a family history. There is no genetic testing to identify if you're at increased genetic risk. It's just simply screening general population for islet autoantibodies as well as for celiac disease. And what you can see is estimate about a third of those approached agreed to screen through the ASK study. I'll note that TEDdy includes an extensive psychosocial protocol, which was developed and led by Dr. Suzanne Johnson. And this was used to assess participants' understanding of their risk for type 1 diabetes, any anxiety about that risk in developing type 1 diabetes, and any behaviors that families initiated to try and prevent the child from developing type 1 diabetes. ASK, I would argue, is a little bit more similar to what we might see if we do universal screening programs, where large numbers of people are approached about islet autoantibody testing, but they very, very well may have no background knowledge about type 1 diabetes before doing that screening. And in ASK, we are also kind of piggybacking on some of the measures used in TEDdy to assess those different constructs, which I'll get into more detail in a little bit here. Okay, next slide. The other ones you might hear a little bit about, but they don't, there's not quite as much published literature on the psychological aspects of screening from these groups. So is TrialNet. And that's an international consortium of academic centers that screen family members for islet autoantibodies, monitor them if they're positive. And then they also offer intervention trials to anyone found to be positive for islet autoantibodies. So they do not have to screen through TrialNet to enroll in those prevention or new onset trials that are seeking to preserve beta cell function. Lastly, I might rely on a couple examples from our early T1D clinic at the Barbara Davis Center. So this is a clinical care program, so it's not research. We bill insurance. The early T1D clinic director is Dr. Kimber Simmons. And in this clinic, patients are evaluated for disease-modifying therapies like teplizumab. And as a psychologist, I conduct health and behavior assessments with patients and families who are new to the early T1D clinic. And I'm available as needed for follow-up patients, although the majority of patients do not require follow-up. Okay, next slide. Okay, so humans are often stressed when they're faced with things that are threatening, unpredictable, and uncontrollable. And type 1 diabetes really can check all of those boxes, or at least it can be perceived that way by many. So, type 1 diabetes is threatening in that it's a serious illness that never goes away. It's unpredictable. Right now, we cannot tell you exactly when you will get clinical disease. Of course, they are working on trying to be more precise with that, but right now we can't tell you. And for many families, they're told any day now, and then that could be years later. And it's uncontrollable. So we don't actually have a way of stopping you from getting it. We certainly have made progress in terms of obviously delaying onset, but we can't actually stop you from developing type 1 diabetes. So for those who screen for antibodies and are found to be negative, these results may provide a sense of relief. But if the results come back positive, it may have a significant impact for many people. And so given this, I think part of having a really successful screening program means being prepared to address any psychological concerns that come up from your patients and families, which is what we're talking about today. Okay, next slide. So when we think about how to assess someone's psychological status or the impact of being diagnosed with early stage T1D, first, there is general psychological functioning. And this is referring to how the person functions in everyday life. And it can include mental health disorders like depression, anxiety disorders, post-traumatic stress disorders. And measures that assess these constructs are commonly used if you want to compare one group of patients to another group of patients with a different condition, or to healthy controls, for example. And so, although the majority of people with type 1 diabetes do not suffer from a mental health disorder, we do know that mental health disorders like depression, anxiety, and eating disorders are more common in those with type 1 diabetes. So perhaps it's understandable that many are approaching looking at the impact of autoantibody screening or a diagnosis of early stage T1D from this point of view. But in type 1 diabetes populations, and really in behavioral medicine in general, our disease specific measures are a much more sensitive assessment of the psychological impact rather than our general mental health measures. So, we also look at type 1 diabetes risk specific psychological functioning, and typically these have been kind of grouped into three categories: cognitive, behavioral, and then emotional impact. So we'll touch on each of those. Okay, next slide. So just to start by mentioning the general psychological functioning. In the literature, I mentioned that looking at studies of children who have clinical type 1 diabetes and their families, we see type 1 diabetes can have a significant psychological impact on the patient and the family. But we also know that although type 1 diabetes increases one's risk for several psychological disorders, it is still the case that most people with type 1 diabetes do not have a psychological diagnosis. There's actually very few studies that have looked at the impact of an early stage T1 diagnosis on general psychological functioning. I'll call out one in particular. There's a study from Bavaria, Germany, which gave participants the PHQ, which I'm sure all of you are familiar with, is a screener for major depressive disorder. And the authors reported that the mom's scores on the PHQ were higher than the mom's scores of children who were antibody positive were higher than the scores of children who were antibody negative. But I'll note the scores were in both groups in the less than 5 category, which is like minimal to no depressive symptoms. And then the scores of the moms were lower than the scores of moms of newly diagnosed clinical type 1 diabetes in a separate study. So moms with antibody positive children were a little bit lower than moms of children newly diagnosed, but from a separate study. And then the mom's scores did decline over time, a small amount because they started very low. But the follow-up questionnaires were actually only available for under half. So we have to interpret with caution. Okay, next slide. We don't have any studies that have used validated questionnaires of general psychological functioning. It's really only screening measures like the PHQ that have been used thus far. And really, most of this has been in parents. So we do not have any studies that have assessed general psychological functioning in children with early stage T1D, but there is some good information from Teddy we can take, which showed that there was no evidence that the Teddy parents were more depressed than the general population. There was no evidence that the preschool-aged children in the Teddy study had any more behavioral problems than the general population. And there was no evidence that antibody-positive preschool-aged children in the Teddy study exhibited more behavioral problems than antibody-negative children in the Teddy study. Okay, next slide. Okay, so there's a somewhat larger literature looking at disease-specific measures. Like I said, most of this is focused on parents, and there's very little data on the child self-report themselves. But like I said, we kind of group this into 3 categories. So first, the cognitive aspects refer to kind of talking about how well are people understanding their risk for going on and developing clinical type 1 diabetes. Risk can be an abstract concept, and so that can be hard for some. The behavioral impact, meaning what are people doing in response to learning this information that their loved one has antibodies or an early stage type 1 diabetes diagnosis. And the emotional impact, referring to how people are feeling about having antibodies or an early stage type 1 diabetes diagnosis. Okay. So the next slide is, okay, let's start with the cognitive impact. So let's start with how people are people understanding this. In Teddy, most caregivers, so 90% of the moms and 3/4 of the dads of the multiple antibody positive children believed their child was at increased risk for type 1 diabetes. However, many parents whose children were at increased genetic risk, which reminder was a requirement for being enrolled in the Teddy study, but did not have multiple antibodies, underestimated their child's risk. We have one study that looked at how children in Teddy understood their risk for developing clinical type 1 diabetes, and we saw that a little over 3/4 of the 14 to 15-year-olds, which is the end of the Teddy study, with persistent positive multiple islet autoantibodies, believed that they were at increased risk. So we had about a quarter who were reporting they were not at increased risk despite being enrolled in the Teddy study for 15 years and having multiple islet autoantibodies. When we look at ask, it might give us an opportunity to see how people understand their risk, perhaps a little bit more of what it would be like to screen just like the general population because they're not enrolled in a study for 15 years. And we saw that about 2/3 of the ask parents or caregivers of children who were positive for multiple islet autoantibodies had an accurate risk perception for their child's risk of developing type 1 diabetes. And one of the reasons we care about all this is it turns out that risk perception accuracy is associated with a variety of important factors. And importantly, those who underestimate their child's risk were more likely to not follow up in some of these longitudinal studies, which means that if we're following families for a long period of time, because again, we don't know how long it'll take someone to develop type 1 from the time they're screened to the time they're diagnosed, that underestimating risk might be a risk factor for those who would prematurely withdraw from the study or stop following up. Next slide. The other thing I think it's important to note as clinicians is that naturally risk perception declines over time. So the image here is actually from PANDA, which is an early study of US children at increased genetic risk for type 1, most of whom had first-degree relatives. And what you see here is that most mothers accurately estimated risk 1 month after they were notified of their child's risk, but that risk perception accuracy declined over time. So you see the blue bars got bigger over time. That's the percentage of parents who were underestimating their child's risk. This makes sense. I see this clinically. If you're told your child's at increased risk and then you go years without developing type 1 diabetes, people start to be like, well, maybe they won't get it. But I think it's important to know as clinicians because we need to continuously make sure we're educating families because we don't want to have this trend we saw in PANDA where the underestimators increase over time happen because then we know that they're at risk for kind of premature withdrawal from the monitoring program or the study. Okay, next slide. So when we look at how well these kids are understanding their risk, you can see that at age 10, this is from the Teddy study, about 40% of kids felt unsure about their risk when they were asked the question. They were like, I don't really know. With the remaining children evenly split between those who believe they were at increased risk for type 1 diabetes and those who did not believe they were at increased risk for type 1 diabetes. As the children grew older, you saw the percent of those who were unsure declined, which is great. So 15-year-olds understood a bit more than the 10-year-olds. But the even distribution between those who believed they're at increased risk and those who underestimated their risk actually remained. So at age 15, we had only 45% of the teens believed they were at increased risk for type 1 diabetes, despite the fact that they were enrolled in this study from birth. Okay, next slide. And in Teddy, they created a series of books to help kids understand their participation in the study and what it meant to be at risk for developing type 1 diabetes. And so for anyone who's interested, these books are actually now available for free on the NIDDK Central Repository. So the books were like, the first book is We Go to Teddy, was provided to families when children were 2 years of age. It describes steps of doing the study visit. The second book, Will and Emma, Junior Scientists, provided some additional details. And that was provided between about 5.5 and 7. And then finally, the book Will and Emma Meet the Teddy Scientist, that was provided at age 10 and provided information on, what is the autoimmunological process underlying the development of T1D and explain this kind of concept of risk. And so that is available in a couple languages on the NIDDK repository. We also looked at factors that predicted the children were likely to say they were at increased risk for type 1 diabetes and TEDdy. And we found that actually children from the US and Sweden were more likely to say they were at increased risk compared to Finland and Germany. Older children, which makes sense, females were more likely to be accurate about their increased risk. Children who had a first-degree relative with type 1 diabetes were more likely to say that they were at increased risk for type 1. Children who had a highly educated mother, who had a mom who perceived them to be at increased risk, children who had more than, greater than or equal to 1 islet autoantibodies, and children who read the book. So good news is that the book seemed to help kids understand this concept. The bad news is that, it was a small effect and all of these factors played in, but it was helpful. So that's great. Okay, next slide. So to summarize, what do we know about the cognitive impact so far? We know that risk communication can be difficult, and there are many families who struggle to kind of understand, especially the younger children. We know that older children understand the concept of risk better than younger children. We know that moms and girls are more likely to be accurate about the child's risk for type 1 diabetes than dads and boys. We know that the less educated parents and those with no family history of type 1 diabetes may have more difficulty understanding this information we're providing them. And we know that having a positive test for islet autoantibodies leads to improved understanding of estimating type 1 risk in both children and parents. And we know that books and other efforts to help participants understand their risk may be useful, but we'll need to continually tailor and repeat this information to help families maintain that accuracy and risk perception over time. Okay, next slide. So, sorry, this one has a couple clicks to get the bubbles to pop up. One more. Perfect. So I like to take all of this, research information we have from a couple decades and say, well, what are we seeing in clinics? So this is in bold, you see one of my favorite questions to ask kids is, I know what the doctors have told you, but I'm interested to hear what you think the chances are that you'll develop type 1 diabetes. And I'm not pulling quotes that are maybe the most representative. Like most people in our clinic do understand, but I'm pulling the ones that are maybe most interesting for stimulating discussion and thought-provoking. So we've had a parent of a 13-year-old say, I do not think she will get diabetes. She is thin and healthy. And then I've had a parent of a 17-year-old say, the doctors have been saying any day now for the last 7 years. And here we are. I don't think they know what they're talking about. Okay, next slide. So the next thing to talk about is the behavioral impact, which I actually think is maybe one of the most interesting. And this includes behaviors that individuals may engage in to monitor for any signs or symptoms of type 1 diabetes, as well as behaviors that individuals report engaging in to try and prevent development of the disease, even when they are told there are no behaviors to prevent their child from developing type 1 diabetes. So we learned in TEDdy that many parents of children at increased genetic risk for type 1 diabetes engaged in behaviors to try and prevent their child from developing type 1 diabetes. Diet changes were the most common, but some parents also reported starting checking their child's blood sugar at home, even when they were not instructed to do so. We also saw from TEDdy data that engaging in any harmful behaviors was rare. But I have seen some patients where a family believes they're doing something that's really helpful, and it's actually maybe having a negative impact on the child. So for example, I had a 12-year-old girl tell me that the worst part of learning she had multiple antibodies was that the family decided to cut gluten out of the whole house. And then her sisters blamed her for this and complained about like the restricted diet as a result of her antibodies. And when we were able to explain to the family that this wasn't actually going to change anything about her risk, they went back to eating gluten, and that was really helpful for the child. And we don't actually have any published data yet on what children say they are doing, if anything, to try and prevent themselves from developing type 1 diabetes. But these data are being collected in TEDdy starting at age 10. And so hopefully we'll have some of that available soon. Okay, next slide. So in your clinical practice, you may want to ask questions like, are you doing anything differently since you learned this information, or has this news caused you to make any changes lately? And then this is the quote from the 12-year-old I mentioned, which said, when she said, the worst part of all this is eating gluten-free and my sisters are mad at me for it. The good news is that was easy to change. Okay, next slide. All right, so finally, let's talk a little bit about the emotional impact. Next slide. Before I do that, I just want to explain one thing, which is the difference between trait anxiety and state anxiety. So trait anxiety is a pretty stable characteristic. It tends to recur when evoked by a stimuli. Like we all have friends who tend to respond to stressors with some anxiety, right? It's a trait and more stable about that person. And that's because these individuals are perceiving the world in a certain way. And so they tend to respond to different stimuli in their environment in a predictable pattern. State anxiety, in contrast, refers to an emotional state that exists at a particular moment in time at a particular level of intensity. So it could be a reaction to a particular event. This is a good measure if you want to understand how anxiety changes from before taking the MCAT to after, or other standardized test, or from before getting information to after getting information, or from waiting in the doctor's office waiting room until after the appointment. Okay, next slide. So most studies that have assessed anxiety in response to type 1 diabetes risk have used the state anxiety inventory, which is appropriate because they're interested in understanding kind of the patient or the family's response to a particular stressor in their lives. The SAI, the state anxiety inventory, measures feelings of tension, anxiety, and nervousness at a single point in time. Participants are asked to think about their own risk or their child's risk for type 1 diabetes when they respond to the items. And this measure is actually, the original version is 20 items of state anxiety measures and 20 items of trait. But because that's a bit lengthy when you're giving multiple measures, they actually were able to shorten it down to a 6-item version in the TEDdy study, and there's a regression equation that allows you to convert the scale from your 6-item short form to that of the main scale, so you can kind of interpret it across other populations. And then there's a child version that is given to children every year in the TEDdy study starting at age 10, and we are also giving that in the ASK study. Okay, next slide. Okay, so a lot of what we know about anxiety in this population comes from TEDdy, which, of course, we need to recognize that there are limitations on how we're generalizing that, but they have provided us with really excellent foundation in understanding this. And so importantly, when we're talking about state anxiety, we are not saying that an individual has a diagnosable anxiety disorder. Rather, we are talking about anxiety in response to potential stressors, and it should be sensitive to change over time. That's why it's a state anxiety measure, and so that is why it's appropriate for assessing anxiety in this population. So on the screen here, you're seeing anxiety scores of caregivers of children enrolled in the TEDdy study who tested negative for islet autoantibodies and remain negative over time. So on the x-axis is the child's age in months, and on the y-axis is the anxiety score. So the red line is moms of children in TEDdy who have a first-degree relative with type 1. The dark blue line is the dads in TEDdy who have a first-degree relative. The light blue line is moms who do not have a first-degree relative. And finally, the dads in TEDdy without first-degree relatives are in that gray. I have a bold black line at 40, which is considered high state anxiety. And so you can see the moms of the TEDdy children who have first-degree relatives with type 1 were a little bit anxious when they were told about their child's increased genetic risk. But this declined over time for all groups and remained below the cutoff of 40. And again, these are the parents whose children were at increased genetic risk. So they were enrolled in TEDdy, but they had negative autoantibody results. Next slide. In contrast to parents of children who remain negative for antibodies, these images here show state anxiety about diabetes in the moms and dads of the TEDdy participants after a child tested positive for an antibody. Okay, so the dotted line, the bottom one, is cases where the child had a single positive test result, but it went away and never came back over the 4-year window. The dashed line is parents where the child had a positive antibody and that stayed positive over time. So it's called single persistent. And then the solid line is the cases where the child had an antibody test result that was multiple. So they had more than one autoantibody and that stayed persistent over time. So what you can clearly see is that moms on the left are more anxious than the dads on the right, which is consistent with literature on anxiety, that females tend to be more anxious than males. And that we see that the caregivers of the children with multiple persistent islet autoantibodies are the most anxious. And that over half of the moms had high anxiety 1 year after the child's first positive test result, and 43% were high above 43 years later. So the dads were a bit less anxious, with under half highly anxious at 1 year, and about 1/3 were considered highly anxious at 3 years after that initial test result. Okay, next slide. So all I did here was add one thing to the screen, which is that blue star. And the blue star is the mean parental anxiety at the very first monitoring visit in the ASK study, which, if you remember, is the general population study where we're not enrolling people at birth who are at increased genetic risk. We're just screening anyone who's willing to screen. And so you see it's a bit higher. I think that there's a variety of factors that might contribute to that. One of them being that, those who enrolled in TEDdy knew from an early time that their child was at increased genetic risk. And so perhaps finding out that they had antibodies wasn't as much of a surprise as those who were just kind of screened in the general population. There's other things, like we have a higher Hispanic population in the ASK study, and we know that ethnic minority status is actually associated with higher anxiety. So there could be a variety of factors contributing, but overall we saw higher anxiety in the ASK study compared to TEDdy. Next slide. And then this is just from an article we published looking at, well, what factors are associated with having higher anxiety? And we see that in a multivariate linear regression that the factors that came up were parental education, such that, those with lower education were having higher anxiety, the child's race or ethnicity. And so, like I mentioned, those who were minorities had higher anxiety, and then the parents' risk perception. So if they accurately understood that this meant their child was at high risk for type 1 diabetes, they were more likely to be anxious. Okay, next slide. This is unpublished, but this is just the percentage of children who report having high anxiety about developing type 1 diabetes. And again, the same pattern emerges where the ASK cohort is a bit more anxious than the TEDdy cohort. Okay, next slide. So why care about anxiety if you're not a psychologist that likes to address it? One thing is that it's been time and time again associated with study dropout or engagement in monitoring over time in these monitoring studies. It's associated with engaging in behaviors to try and prevent oneself from developing type 1 diabetes, even when we don't know that there's any way to do that right now. And it's actually a top concern reported by providers. This is a study of pediatric and adult endocrinologists in the United States when they were asked about their willingness to engage in autoantibody screening. And you can see the farthest on the left, those two are anxiety for patient and family, and then cost to the patient. So I know that Canadian healthcare system cost is very different than the United States, but the point being that anxiety is a top concern for providers. Okay, next slide. So to summarize, what do we know so far? We know, like I said, moms are more anxious than dads. We know parents with a family history of T1D may be more anxious than parents without a family history. We know that repeated negative islet autoantibody tests are associated with a decline in anxiety over time. And in contrast, islet autoantibody positive test results may increase one's anxiety. We know that anxiety is greatest in those who have children with multiple islet autoantibodies. And that for some subset of them, not everyone, but a subset of them, they may have anxiety that can persist over a longer period of time. And we know that ethnic minorities tend to have higher anxiety than non-Hispanic whites. And then we know that there is a substantial group of children who may be anxious, but we really don't know a whole lot yet about the factors that are associated with that anxiety. But hopefully we will soon. Next slide. So these are responses from clinical patients that I've seen when we kind of think, like I said, talking about these are all of our research findings, but how are we seeing this manifest in clinical practice? Again, these are not like representative. They're just some of the more interesting ones that I've had. So I like to ask, have you noticed any changes in your family's level of stress? For younger kids, I like to ask, how much space is diabetes taking up in your brain? And these are some of the responses that we've gotten from kids, from young adults, you know, thinking that seen people who were planning to go into the military or even become a pilot. A mom who says that their child feels like a ticking time bomb, and then a 14-year-old who was wearing a CGM for monitoring and ate 4 rice cakes, which led her to have a blood sugar of 300. And she told me she will never eat rice cakes again, and she does not want to give insulin at school because the other kids already look at her weird when they see her do a blood sugar check or when they see her say GM. Next slide. And then, you know, I think it's just important to note that although anxiety is a common response, it is absolutely not the only response that patients have when they learn they have islet autoantibodies or receive an early stage type 1 diabetes diagnosis. So I like to put these up here. And here you can see there's a large variety of responses that we hear from patients. So patients who report feeling shock, feeling like it's unfair, feeling overwhelmed, tired of playing the waiting game, wondering when their child's going to be diagnosed. And then other patients who express a sense of relief, knowing that they continue to engage in monitoring, they're going to be able to catch this early, that they won't be diagnosed in the hospital, that they can do something about the fact that they're in stage 2 type 1 diabetes if Tzield is available in their country. And knowing that they will get diabetes has provided them time to prepare. I've had a family say they started reaching out to different families with type 1 diabetes, which is lovely. They're already proactively seeking social support. Next slide. A few more quotes from people. Some people, like I said, saying they already started reaching out to build social support. And others viewing delaying T1D as a negative because they felt like the stress of monitoring and worrying about becoming a diabetic was really overwhelming for them and their family. Next slide. Okay, there's a lot we don't know. And I just like to highlight this, you know, the impact of screening and the knowledge of having high risk for type 1 diabetes on other family members. I think it's really interesting to think about siblings who already have type 1 diabetes when their other sibling screens positive for islet autoantibodies. I've had a teenager tell me that they were frustrated that their sibling got to receive Tzield and that was not available to them, but that they were also feeling guilty for even having that thought. So really interesting things going on there with family members. Lots of questions remain unanswered about the impact of long-term medical monitoring on those who are at risk, who have not even developed a clinical disease yet, but have a lifetime ahead of them of engaging in a pretty burdensome self-management routine. So how long will these people agree to be monitored? Does it influence the likelihood of them joining a prevention study? Does it impact their adjustment to type 1 diabetes when they do go on to develop clinical stage 3 type 1 diabetes? What about the people who are told they're at high risk but don't actually develop type 1 diabetes? And then, you know, other things to think about is, as we do this, is how are we going to manage limited resources And of course, all of us are looking for more mental health providers for those who already have stage 3 type 1 diabetes, and how are we going to help to best utilize our resources to help those who are at risk as well. Next slide. I'll just wrap up with mentioning one of the things I'm working on, which I think is really exciting. So, I've highlighted for you here that there are high rates of state anxiety in many of these patients. But despite detecting this, no one's actually developed an intervention to address this yet. And I've been lucky enough to be funded by Breakthrough T1D to use a mixed methods approach to adapt cognitive behavioral therapy, which, as I'm sure many of you know, is an evidence-based intervention for anxiety for parents and caregivers of children who are experiencing high anxiety about their risk for developing diabetes. And then we are purposely purposely sampling higher rates of racial and ethnic minorities, given that we know that they have higher rates of anxiety in this population. And we're using the NIH orbit model. Next slide. Which, if you're not familiar with it, you can actually go to the next slide. What we're doing is following this model to try and develop an evidence-based treatment for this population. And so the first step is essentially just defining the problem, developing a hypothesized model for how you're going to treat that problem, identifying our appropriate treatment group. And so for this study, we've identified the problem, which is that there are high rates of anxiety, but we don't have any evidence-based interventions for that yet. We've identified a potential treatment, which is cognitive behavioral therapy, which we know is a gold standard approach for anxiety disorders. And we've identified participants, which is youth with early stage T1D and their caregivers who are highly anxious about developing type 1 diabetes. Next slide. And so then the next stage is to refine the intervention to identify, appropriate components and dose, et cetera. And so what I did for this phase is interviewed families about their experiences, got their feedback on what they would change in an anxiety intervention, et cetera, and developed, using all of that qualitative data, adapted a cognitive behavioral therapy approach to create a treatment manual ready for testing. And then the last slide is what we're doing now, which is essentially determining if this treatment can achieve any clinically meaningful change on our target of interest, which is anxiety. And so this is a treatment-only design where we're piloting with small cohorts of, 5-ish families at a time, and then iteratively refining based on participant feedback to achieve maximum acceptability and feasibility. And hopefully a signal that we are able to reduce anxiety in this population. Next slide. That's it. So if anyone has any questions, it looks like we have 10 minutes left.
Jen, do you want to read them or do you want me to?
I just have one here that I can see, and I can read this one out from Jess Forster. For families of adolescents with stage 2 type 1 diabetes who become highly anxious about dysglycemia and start restricting foods in ways that resemble disordered eating, what should healthcare providers do beyond referring to an eating disorder program? And how can we support safe monitoring without reinforcing food fear or glucose hypervigilance?
Yeah, this is a really important and great question. Okay, a couple practical tips. I see it the most when kids have constant access to their CGM data. So, the kid who is wearing a CGM for the purposes of monitoring and seeing, what their blood sugars are doing, because people are really wanting to use CGM sometimes instead of OGTT because it feels more tolerable to the patient. So like I mentioned, that patient who noticed, oh, rice makes me go really, really high. I'm not eating that anymore. She definitely started developing kind of disordered eating behaviors. So practical suggestion is don't put the CGM on their phone. Put it on like their mom or their dad. If you need to collect CGM data for medical reasons and medical monitoring, see if you can use the parent's phone as the receiver so the kid is not like checking their phone while eating to see exactly what's happening. If that's not possible, I would actually kind of treat it like a checking behavior almost in OCD and work on decreasing their urges to check. I think it's an anxiety driven behavior that they want to know and reassure themselves that they're not developing type 1 diabetes. So I would essentially treat that urge to check their blood sugar so repeatedly as an anxiety based behavior where you have to do exposure and response prevention to help decrease it. The other thing we'll do is we have is to show them what a person without diabetes CGM tracing looks like. I think a lot of people have this thing in their head that like they're supposed to look flat and that means better. And so we show them that like you are supposed to go up and down. And then that's normal. And the doctor does a really great, or the doctor I work with does a really great job of educating patients like, you know, one spike isn't a bad thing. You know, we're doing this to look at patterns of your blood sugar over time and normalizing that we are going to see some ups and downs and what that means your body is doing. Like I try and tell kids, well, it means your body's working, right? The fact that your blood sugar is going up and down is actually a good sign. So I think that the sort of the question brings up one of my biggest concerns in this population, which is we already know people with type 1 diabetes have high rates of disordered eating. I really hope we're not going to make it worse by what you're saying, which is some of the kids kind of starting to restrict carbs before they even go on to develop actual clinical type 1 diabetes. So I think as much as we can get ahead of it, of avoiding obsessive levels of checking, of working on anxiety when we see it coming. Of course, if you really are concerned about them having disordered eating, of course, sending to a disordered eating treatment center is appropriate. But I think we're going to have to do a lot of liaison work with them to help people who are not familiar with type 1 or much less early stage type 1 understand why we're concerned and the unique kind of aspects that we're seeing here with eating behaviors in early stage type 1.
I have a question about research, qualitative research, or any that has been done. It sounds like not much on families and patients' experiences following screening. So many years later, for example, whether they become just at the end, if they would advise or do the same, I guess the question would be, because there all of those quotes, there's kind of some families who could prepare and were so happy that they had screening, and others, I wish I would just have gotten it or get it. I've been waiting for 7 years. So are there any plans to do those kinds of studies to learn from the experiences that people are having?
There's actually an increasing amount of qualitative research coming out about patients' experiences. I think a lot of families, and again, it's hard, right? Because qualitative research, we're not supposed to really be drawing conclusions about a specific population. Qualitative research is supposed to be more hypothesis generating, not hypothesis testing. So I think we have to be careful about what conclusions we're being drawn. But there are a lot more studies of people interviewing these families coming out. And I think a lot of families, even if they say like that it's really hard or that we wish we would just hurry up and get it, like also say that they're glad they know and that they know that there are valuable things they're doing to protect their child's health and that they're going to avoid DKA. And these are this like thing that psychologists can like to work on, right? Like those, you can have anxiety and you can have appreciation at the same time. And they're not mutually exclusive. So, I think, yeah, from what I have read, a lot of the qualitative work, people are saying that they're glad they know, even though it is stressful information for them to have. But again, we should be careful that we're not drawing too many conclusions based on work that's supposed to be hypothesis generating, not testing. I've seen a few families who've said like, we wish we didn't know, but not the majority. But I think that those people just don't follow up. I think the ones we're seeing in clinic, like they want to pursue this. I mean, we have to remember that lots of people screened, like our rates are not 100% for getting them to come back. So I think the people who don't want to deal with it or don't want to know are probably the people who are not coming back to clinic after screening.
Thank you. Does anyone have any other questions? I know that we have a PDN leadership table as well that comes together quarterly, and one of the topics that has come up also is equity around screening, and it seems to be accessible now through research studies and things like that. But what happens beyond that when it becomes, that it's a cost to families? What
Yeah.
do you see in your practice that way?
I mean, I think this is a moving target, right? Because in our research studies, like the monitoring is free to families. But you're right that, say a family then wants, at least in the United States, we have teplizumab approved. You guys do too, I believe, for delaying onset of stage 3. So that's billed through insurance, right? And that for us, different insurances cover different things. I think for right now, the drug company that owns teplizumab, Sanofi, has a really great, it seems to me at least, patient assistance program where at least for our patients who've been denied coverage, they've been able to get it through their patient assistance program. So that's really great. I don't know that much about like how long is that going to happen or what the plan is for that. But for right now, everyone who's wanted to get that drug has been able to get it, at least at our center. They've just gotten the patient assistance program, and so the drug company has paid for it. I think historically the families who have been more engaged in screening might be, like you have to remember we're asking people to take time out of work, time out of school, et cetera, to come in for these monitoring visits when they don't actually have any symptoms. So for families who are struggling with other things in life, they may not be this might not be at the top of their priority list to come in for a monitoring visit when they don't feel ill or this doesn't feel very salient to them, right? So I do think that is important. How do you minimize the burden so that, families where getting to a medical visit is not that easy can also participate if they want to.
Wonderful. Thank you. Thank you so much, Dr. O'Donnell, for your presentation today. This is such an important topic for this group and for our PDN. It was lovely having you today. Thanks
Thank you
so
for having me.
much. Just a couple of quick things about the PDN. You'll be receiving an evaluation survey. Your feedback is really important, so if you could fill that out, that would be wonderful. Upcoming PDN webinars will be announced in the coming months. And we'd like to share this one slide as a knowledge user on the Bridge T1D study. We'd just like to remind everyone that they are in the midst of recruiting and they are doing their best to have a low burden for participation. And so no patient recruitment, no obligation for PDAPs to attend sessions, and they will provide support from their team along the way. And so we'll send some extra information about that should you want to participate. And you can contact them directly. Their info is on this slide, and I'm sure many of you know them directly. So thank you again, Dr. O'Donnell, for being here today and for your presentation. Everyone have a lovely day. Thanks so much.